damning clinical judgment in the High Court attested that this fetus would not survive. A futile exercise, the High Court said, but it happened because of a medical legal interpretation of the Eighth Amendment, and it could happen again. So in addition to being an obstetrician, I'm a specialist in fetal and maternal medicine. NMH is a large tertiary centre for fetal medicine. We're fortunate to have a large multidisciplinary team, including neonatal, midwifery, bereavement, radiology, paediatric, obstetric, genetic, social work and pathology experts to provide the guidance and expertise that is required in the context of a complex fetal anomaly. Care pathways have been developed that adopts a multidisciplinary approach to provide individualised care to families. We see women from all over Ireland, and we know it's very difficult for families who have to travel long distance for care in the context of fetal anomaly. In 2016, 195 women with fetal anomaly were referred to NMH from units around the country. Specialty of fetal medicine is increasing in complexity, and our ability to identify genetic and structural anomalies in the fetus in utero is increasing. New techniques include the ability to detect chromosome abnormalities by testing free fetal DNA carried in the mother's bloodstream from as early as 10 weeks gestation, and this is done using a simple but expensive maternal blood test. Microarray allows us to look at the chromosomes and see genetic material more clearly, and fetal imaging has improved, including enhanced ultrasound and more recently MRI imaging provided in NMH. Interestingly, 1/3 of units in Ireland do not provide routine anomaly scanning, which is hard to justify in 2017. In 2016, in NMH, we identified 400 significant structural anomalies and over 60 chromosomal anomalies. The diagnosis of a major fetal anomaly, and particularly a fetal anomaly in which survival is unlikely after birth, is a really difficult part of my job. You know when you give such devastating news that you change a family's life irrevocably. Counselling is always non-directive and includes the variety of options available to each woman in each particular case. And even where there is a strong likelihood that a fetus will not survive, women will wish to continue their pregnancy knowing that what will be, will be. They tell me that whether or not their baby survives for a minute, an hour, a day or a week, this time is of infinite importance. The fetal medicine team, the multidisciplinary neonatal teams, in conjunction with our bereavement team, support parents in this context as best we can in each individual circumstance. We now have national standards of bereavement care which address anticipatory bereavement. Strategies include individual care, memory-making support and advice for family members, bereavement counselling, and some people call this concept perinatal hospice care. But for some women, the decision to continue with the pregnancy can be associated with increased maternal risk. For example, in the case of conjoined twins, where separation is not possible because of organ sharing, there are real technical deliveries in delivering conjoined babies who reach term, requiring really high-risk caesarean surgery. Now, some women, in the context of a really severe lethal anomaly in which a baby is unlikely to survive, will not wish to continue their pregnancy, and they will choose to navigate this tragic circumstance in a different way. And I understand that people will make different choices when faced with a really difficult personal situation. 60 women attending our service travelled to the UK for termination of pregnancy in the context of fetal anomaly in 2016, and to date at Holles Street, 43 women have travelled in this context. The majority of women had pregnancies complicated by chromosomal or genetic anomaly, multiple anomalies, anencephaly and ventriculomegaly. The UK data tell us that in 2015, 135 women travelled from Ireland to the UK in the context of fetal anomaly where they terminated their pregnancy under Clause E, substantial risk of physical or mental handicap as to be severely handicapped. But women who choose this option must travel to a different jurisdiction. The Constitution protects women who decide to travel, but a termination in this country, in this context, would be a criminal offence. As an obstetrician, I can give limited practical support in this decision. This includes contact details of fetal medicine centres in the UK. We do not make direct referral for pregnancy termination, and we certainly don't advocate for one management option over another. Parents must make their own appointments and make their own travel arrangements, and I think families must find this particularly cruel. Parents also bear the cost of treatment in the UK, which can run to over €1,000, including medical treatment, flights, accommodation, laboratory bills, and the cost of bringing their baby's remains home. In this context, parents frequently report feeling abandoned, and the tragedy of their loss is exacerbated by the practical difficulties of bringing their baby home, navigating a different city and jurisdiction, being separated from their families at such a difficult time, and the shame and stigma that is associated with travelling to England for termination of pregnancy. From a clinical perspective, care between two different jurisdictions is inevitably disjoint and clinical risk is increased. I'm I'm struck by the findings of the UN Human Rights Committee, which on several occasions have found that the current criminalisation and restrictive abortion provision in Ireland today violates women's human rights, including the right to freedom from cruel, inhuman or degrading treatment, the right to privacy and the right to freedom from discrimination. So I've raised a number of difficult issues which I've encountered in my medical career. No law will ever adequately address the reality of the ethical dilemmas generated by human reproduction, but we have to acknowledge the real risks that women face in clinically complicated pregnancy. I believe there are two main domains that need to be addressed from a clinical perspective. We must address the criminalisation of medical care in Ireland. At present, a woman must have a substantial risk of dying before she can qualify for a termination of pregnancy to save her life. Failure to adhere to this is punishable by a 14-year custodial sentence for both the woman and her doctor, and I believe this has the capacity to create clinical risk by distorting clinical decision-making. In September 2017, the Council of the Royal College and Gynaecologists voted strongly in favour of supporting the removal of criminal sanctions associated with abortion in the UK. They said, "We believe that the procedure should be subject to regulatory and professional standards in line with other medical procedures rather than criminal sanctions." It is also very difficult that our Constitution protects women to travel in the context of a baby that has a fetal anomaly that is unlikely to survive, and yet to terminate a pregnancy at home in this country, in this context, is a criminal offence. Secondly, we must address access to safe clinical care. Women require safe healthcare and sound clinical decision-making in the context of pregnancy complicated by severe maternal disease. A woman herself should have an input into her care management, and both she and her doctor must have the flexibility to make sound clinical decisions in good faith. It should not be a requirement that she is dying prior to these decisions being made. Timely, appropriate clinical decision-making in pregnancies associated with significant maternal risk will make women safer. And of course, children require special consideration in relation to risk. And in severe fetal abnormality, in terms of access, women are currently travelling to jurisdictions outside of Ireland to access complex medical care. While doctors provide non-directive counselling and can provide information on termination of pregnancy, doctors cannot make appropriate clinical referral. Care delivered between jurisdictions raises all kinds of risk, including lack of continuity of care, inability to access timely care, incomplete evaluation and confirmation of prenatal diagnosis, and incomplete analysis of the implications for future pregnancy. Patients would much prefer to have the option to access this care at home, close to their families and friends. So finally, the presence of the 8th Amendment in our Constitution creates unacceptable clinical risk, and it should be removed.